Hello, testing. Hello. Let me try this. Hi, welcome. Welcome everyone. Welcome today to this long-term care initiative night. Just getting settled. Everyone's talking and having a good time. That's good to see. I can hear you. Yeah, am I loud enough? All right, everyone just take your seats. All right, thanks. All right, welcome everyone. Welcome to this learning series on proton pump inhibitors and vitamin D in long-term care. My name is Megan Schultz. I'm one of the coordinators for the LTCI. We just changed our name from RCI. It's LTCI now, so it's a bit harder to say, but we thought you were all up for the challenge. So first, I'm just going to spend a couple minutes talking about this initiative from Island Health called the Pink Band Project. Show of hands, who's heard of this before? Okay, good. Nurses, have you ever sent anyone to emerge with a pink band on? Nice. And how did you find it, generally? Just like a meh, yes, terrible? It was good. Okay, good feedback so far. So the goal of this initiative is to improve communication between nurses in acute and long-term care. So the nurses, during a transfer to the emergency, first thing you're going to do is you're going to call the MRP or the long-term care initiative after-hours physician and discuss, okay, I have this resident, I think they need to go to the emergency department. And and to have a bit of a discussion about the why you're sending them and then the when they can come back. And emergency room physicians have asked for this information specifically to be written on the ED transfer form to help with clear communication and so to make sure that we're meeting the goals before they come back. So once you've had that conversation, you're going to complete the ED transfer form and include the why and the when on it in the reason for transfer. And then you are going to take a pink band and write your facility's phone number along with your or the main nursing local number on the pink band and put it on the resident's wrist. And this is supposed to signify to the team in emergency that they are from long-term care and that they come from a place with 24 hours nursing coverage. The ED transfer form you send will also be pink now as well as a second reminder. And then the ED nurse is going to give you a call, and you are going to give them a bit of a handover using iDraw. So who's heard of iDraw before? Perfect. So it's very similar to SBAR in terms of SBAR you use when you're contacting a physician to tell them what you want or what's happening. And then iDraw is what you use with your peers when you want to communicate during a handover with other healthcare professionals. So it stands for Identify, Diagnosis and our current problems, recent changes, anticipated changes, and what to watch for. So this is what the ED transfer form looks like. So you can see on the right-hand side, reason for transfer. There's not a lot of room to write the what and the when. But just, write that there. An example that Dr. Becker gave for me to share is that you could write, a patient fell and can no longer wait there. Please x-ray the left ankle and treat if fractured. Otherwise, return patient promptly. So that's just one example, and we will send out more information to kind of help you have those discussions. So physicians, that your nurse calls you or one of the nurses calls you and says, I'd like to send this person to emerge. Again, try to remind them and have that discussion with them, the why and the when, and ask them to write it on the transfer form. So while a resident is admitted to inpatient care, you can call regularly to start to plan for discharge. If the person went in and they were ambulatory and now they're in a wheelchair, then you can start to make those plans before they come home. And you are allowed to receive updates. It is, some nurses will say because of confidentiality you can't, but you can. So then when they're going back to long-term care, either from inpatient or emerge, hopefully that they will call you to give a verbal handover. If not, I recommend just giving them a call and asking them, or they will complete the bottom of the ED transfer form. which is at the bottom of this form where you can't see it. And then, so if you want any information about the Pink Band project, we do have a number of resources on the LTCI website. So it's vic-si.ltci.com, and you can find that and more on our new website. So just as a general feeling, how are people feeling about this and the discussion of starting to have that discussion of when and what? Anyone notice anything come to mind or any problems anyone sees? Mm-hmm. Well, that is a great quote, and we would like to write that down and share that. So thank you. Anything else? Remember that the medication from the hospital. Right. Yes. So just as a reminder to everyone, when a resident is transferred back to long-term care from inpatient, the orders that the hospitalist writes are good for 7 days. Yeah. All right. Anything else? All right. So during question time, just so you guys know, you will see the speakers in front of you. If you put up your hand and the presenter calls on you, you just press the button to speak into the mic, otherwise, so the other room can hear as well. And then when you're done, please press it again so it turns off so someone else can use their mic. All right. Thank you so much. Now Dr. McKean will be coming up.
Can I just hold it? Yeah. Thank you, Megan. That was great. So, Megan, you gave a great introduction to our Victoria South Island Long-Term Care Initiative website, and that's a tremendous source of resources for everyone to use. As part of the LTCI, we have worked to create a culture of excellence and teamwork in medical care for residents that live in long-term care, and that's through providing resources to physicians and nurses, dietitians, everyone who works in long-term care, and also trying to remove practice barriers. And one of the ways that we do, there are many ways in which we do that. One of the most important ways is, I think, by bringing people and ideas together. For physicians to belong to the Long-Term Care Initiative, you do receive an annual stipend per resident that you have in long-term care. The after-hours call group is a really well-organized call group that allows you to be remunerated for being on call. The call group works very closely with long-term care facilities, so your experience of being on call is really good. The exchanges that I've had with nursing staff in facilities when I'm on call has always been excellent, and I think it's really building a great community between physicians and nurses. We also have a clinical learning series and opportunities for networking. Tonight is an excellent example of that benefit. We also have parking passes for physicians so that they can park in special places at facilities. Fax to email is offered as a service, and billing support, conferences, one-on-one mentoring, tools to improve best practices, how to conduct a good med review, how to conduct a good care conference. We're trying to think of everything and every idea that we can to improve the experience of long-term care for everyone. So if physicians are interested in joining the long-term care initiative, please reach out to Megan or Anne-Beth or Jessica or the other staff that are here. You can also access us through the website that's mentioned at the bottom. You can speak to anyone at the registration desk. Lots of opportunities to reach out. And one of the opportunities that we have coming up is an opportunity for you to participate in these leadership things to help drive what the ideas would be for the curriculum. And so we're looking for physicians and for nurses and other areas of expertise, such as pharmacy or dietitian. I'm looking at some people that I know to join this group and help determine what it is we should present in the year that's coming up. So if you're interested in also becoming, if you're a physician, you want to become a member of our steering committee, that opportunity is there, an opportunity to form this new learning series committee. And that even if that's too much, then we also have a survey that we could send you, and you could check off a list of topics that you might be interested in, or you could volunteer your own idea about what you think that would be helpful to learn about. So everything is available on this, or you can send an email to this very long email address. Everyone's welcome, and hope you enjoy the presentation tonight. Thanks. Are there any questions about that? Pretty straightforward. Great, thanks.
So can you guys hear me okay? Yep. Room 160. How strange that you're next door, but you're that far away. I'm used to it because many years ago I was one of those distributed program guinea pigs for UBC Vancouver Med School, so I'll try to make sure to include room 160. I have met a few of you, but for those I haven't met, I'll just do some brief introductions to who I am and the organization that I work with. My name is Jessica Audie. I'm a family doctor in Nanaimo. I'm one of these long-term care initiative physicians, so I have my own patients at a few facilities. I also do palliative care. Today I'm here in my capacity as a member of the Therapeutics Initiative. How many people have heard of the Therapeutics Initiative? So about half the people in the room. We have some colleagues here today. I'm going to let my colleague Kate introduce herself later, but on the side of the room in room 150 is Alan Castles, who's our communications director. He's brought some materials about the TI and that kind of go along with what we'll be speaking out today. And if you have any questions about the Therapeutics Initiative, you can direct those to him. Very briefly, we get money that originates from the government that's sent to UBC and destined for us to use in a way that mostly is of our choosing, to look at how different drugs are used in the province. Are they effective? Are they safe? And we can do this with a lens without conflict of interest because we don't have any industry funding. And we spend a lot of time on critical appraisal. So we look in depth at the research that's available, and we look in depth at the research that's not available, that's hidden, that's unpublished as well. And we go through it all in detail. That's a group at the TI much smarter than I am, mostly the Drug Assessment Working Group. And then part of our role in the education side is to translate that information into something useful clinically. So that's part of what Kate and I are here tonight to do. And some of the ideas that we have may be controversial, which is why we hope for lots of questions. And some of the things that I'm talking about today will be fairly physician-centered, but there are some other aspects that are not focused on that, because one of the most successful projects I've seen around dealing with proton pump inhibitors, those drugs like pantoprazole, esomeprazole, came actually from a pharmacist working in long-term care with nurses to identify patients who were on this drug and try to figure out why they were on it. And then with that information that the team put together, approaching the physician and teaching them and encouraging them to discontinue. So I hope this information might be helpful if you're interested in doing something like that. So the Therapeutics Initiative has been around for now 25 years, and every few months we send out a letter called the Therapeutics Letter, and one of our first was on this topic. And this is number 3, and we concluded at that time when we looked at these proton pump inhibitor drugs that probably they were useful for people with severe erosive esophagitis. So when you do an endoscopy, they had openings in the lining of their esophagus, but we advised caution going forward because we didn't know very much about the long-term safety of these drugs. And I think you'll see that the last slide could pretty much be the same, that we still don't have a lot of information about the long-term implications. We think there's probably some good uses for PPIs, but we have to be careful about the when and the where and the how. And so I'll walk you through that today. We'll skip over those. And just by way of disclosure, I don't have any financial conflicts of interest. I get some honoraria from various nonprofits, but nothing from industry. And this is my grandmother on the left. She turned 100 a couple weeks ago. She lives at home. My parents care for her, but she also goes into long-term care for respite. So I've also seen the long-term care from that point of view. And that's her visiting the horses down the road. She lived alone for 98 years until she moved in with my parents. And she's still able to go for walks and visit the neighbors' horses. So we're pretty lucky. And that's my son there who is a little bit ill. So if I leave early today, that's where I'll be heading back up to Nanaimo. Has anyone seen something that looked like this in the mail, physicians and nurse practitioners? You may not have. You may soon if you practice in that in a prescribing capacity. The Therapeutics Initiative is trying to empower physicians and nurse practitioners and others who prescribe by giving them information about how many of certain drugs that they use. And so we've kind of reinvigorated something we had done many years ago to share this information with clinicians, along with a little bit of information about their use of drugs. So I just wanted, in case physicians had seen this, to know kind of what it was. And if you haven't heard of it but are interested, I'd love for you to speak with Alan at the break, or myself. All right, let's get into it. Proton pump inhibitors. Here's a kind of a quiz. You don't have to know anything about them to take a wild guess, but I wanted to focus on seniors, and we looked at some of the epidemiological data in BC, and I wanted you to take a guess at how many seniors in BC are taking a proton pump inhibitor chronically. Any guesses? E, 35. Woo, that's high. Okay. That would mean like 1 in 3 seniors are on a PPI every day. C, 10%. D, 20. Okay, no one's guessing A or B, so why don't we look in a little bit more detail? Lots of great guesses. I can't hear from room 160. I'm sorry, but if you have a really conflicting view, I'd love for you to press your microphone and jump in. The TI really likes to talk about PPIs. I'm not sure what drives our passion for that, but here's another letter that we did last year on PPIs, and this one looked at the statistics in BC, and Alan put together all the data from across Canada. And what's interesting, many of you were getting quite high, but the rates you were suggesting were actually the rates that are correct for the eastern provinces. BC actually has one of the lowest rates of proton pump inhibitors used chronically in seniors. I'm here, room 160, I'm hearing lots of oohs and ahs here, probably the same there. That's pretty cool. We're doing pretty well compared to the other provinces. And we're going to talk a little bit more about why that is later. But that's kind of interesting that in the eastern provinces that a third of seniors are on these. And the seniors is age over 65, and this is people who filled at least 2 prescriptions over, I think, a 180-day period, something like that. So more than a couple of weeks. What's interesting, though, and what worries us is that in BC, even though the rate overall is lower than the other provinces, the rate of increase is quite high. Our population has gone up by 20%, but the annual number of PPI prescriptions is now up by 440% in the last 18 years. And maybe that's just due to the availability of these drugs or some belief that they're quite fantastic. I don't know. That's why we're here. It's a similar story in other places, so I looked at some other jurisdictions, and in California, there about 12% of people were on a PPI chronically, and they reviewed about 400 charts. They went through them and found that some of them were low value, and most of those ones that they just felt were low value were people who had the medication prescribed to them for something like GERD, like symptoms that were bothersome, but they wound up just continuing it forever and ever. And I think you'll see later that that's one of the common problems in the long-term care population. Okay. So there's a whole bunch of proton pump inhibitors out there. Some of us may be on them. Some of these you may never have heard of. Can you take a guess at which would be the most effective of these? So you can use brand names if you want, Nexium or... I'm here. I heard one, all the same. Any others as to which is the best proton pump inhibitor? I'm hearing still lots of mumbling of the same. So I think we'll say that's consensus. So you're already well ahead of the curve. When the Therapeutics Initiative looked at this, we couldn't find any RCT evidence that one was better than the other. There's lots of trials that suggest one is better than the other, but if you just adjust the dose to being equivalent, then they're the same. So it's really just a dose effect. And none of these drugs have been compared head-to-head as far as side effects for long-term. There's some shorter trials, but the costs are quite different. So the newer the drug, the more expensive generally. And most of these drugs, they work the same. They have the same sort of active portion of the molecule, and then they have a bunch of other salts and things tacked on to them. So that pantoprazole magnesium, which is a Tecta versus your pantoprazole sodium, similar effect, but just slightly different shape to the molecule. And that's how manufacturers create sort of other flavors. So if anyone who's traveled to Cambodia or Vietnam, same, but different.
What happened to lansoprazole?
What happened to it?
Yeah, wasn't there.
That was just, I just didn't include in the quiz.
Okay, all right.
Yeah, it's still around.
For the North-Asian population, when you have to crush med, lansoprazole becomes very popular.
Yeah, there can be some advantages to different formulations and also to the coverage and the benefits, which I'll show you a slide on right now. So it does depend sometimes on the characteristics of the delivery of the drug, if you can crush it or not, but also to coverage. So in the long-term care facility, you don't have to face this usually, but for seniors who are outpatients, to get these medications funded in the long term, you have to fill out this form. And remember that slide earlier that showed you guys had wildly overestimated how many seniors were on PPIs? I think this is part of the reason. So as a physician, I hate filling out forms because it's just a waste of time. But I think it's, from a TI perspective, Therapeutics Initiative perspective, this form is fantastic because it forces people to think twice and creates an extra barrier to prescribing where it's not needed. So I think this might be part of why our rates are lower than in other provinces. We have someone here, room is 160. There's a person in the audience saying she, or maybe can. I think another one is on. I'm not sure. Can you?
What I was saying is that sometimes coverage is not a deterrent from prescribing.
Okay, so the comment is that for room 160 that the coverage may not be the deterrent from prescribing. I hope in my heart that the Therapeutics Initiative has had a little bit to do with this, but there may be other sources of information and different reasons. And we can talk about some of those things that stop us from wanting to prescribe. I think there's one more comment here. I'm sorry, I don't know how to help you with that. I don't know if any of the division staff could help us with that. I'm going to carry on in the meantime. I think the cameras look to be okay, so I'll just carry on. Now, I don't know if you've heard of any of these conditions before. Some of them might be familiar, some of them might be foreign. But that tells you a little bit about rarity versus the commonalities of these. You may have heard of patients who have a problem where they secrete too much acid. That's just a genetic or another predisposition that causes them to be that way. That would be Zollinger-Ellison syndrome, for example. You might see seniors in your care home who had an ulcer in the past that bled, or they have a documented severe erosive esophagitis. Instead of answering this question, I'd love to hear from you what you think the most common reasons for prescribing or written indication for proton pump inhibitors is. Symptomatic release, okay. Any answer in room 160? Just you're going to have to press your button because I won't hear you. Doesn't look like there's any volunteers there. Okay. Symptomatic relief, so that might be how it first starts. Yeah? Hiatus hernia, I've heard. Okay, well, I've heard a lot of different reasons in my practice, and I want to kind of go into that because I don't think I fully understood that. Before PPIs existed, there were the H2 blockers like ranitidine. You've probably heard of that in the news now with all the recalls and the shortages. But those drugs were not as helpful for the symptoms that occurred in the night. And PPIs were invented, and they seemed to be fantastic. And what happened was people started prescribing them for symptoms like heartburn, acid reflux feeling, and they said, hey, if it gets better, you must have GERD. It's diagnostic. So that got me to thinking, like, how do we diagnose GERD? Because I, as a physician, every time I see a person on a PPI, historically I would write in our list of medical history, I write GERD, because they must have GERD to be on a PPI, or maybe they have a bleeding ulcer, right? So that, I used to do it the backwards way, just like this, see the drug, know the diagnosis. But when I got to thinking and looking at the literature, it was actually a lot more complicated. So if you look at people who come into the office or who are in the long-term care facility complaining of epigastric pain or burning, you can sort of break them down into two categories. The people who have the organic disease, meaning you could do a test to find something wrong, and the people who have functional disease, meaning you could do a whole bunch of tests and you wouldn't find anything wrong. And surprisingly, the majority of people fall into that functional category. So they definitely have symptoms, but you couldn't figure out where they're coming from or why they're happening with any test that we have available to us. And some people call this visceral hyperalgesia. So this might in the future be classified as one of those functional disorders like fibromyalgia, chronic fatigue syndrome, that category of things. And the other group are the organic diseases. So things like having cancer or taking a medication that causes this as a side effect, gastroesophageal reflux, and then PUD, that's peptic ulcer disease, people with ulcers, the majority of which worldwide are H. pylori, but less so in our society, in developed worlds, I should say. And then GERD itself has many definitions and many ranges. You can have acid reflux with signs of scarring in the esophagus or not. Some people have Barrett's esophagus where they have sort of precancerous changes, and there's different classifications. So this still didn't really answer my question of what is GERD, right? It's this range, this nebulous thing, and a lot of people who come into the office or who I see in the nursing home complaining of heartburn, I don't know. Is it GERD, isn't it? I probably need to know that before I write it as a diagnosis. So how do you figure that out? Well, a bunch of people, gastroenterologists, sit in a fancy, I presume fancy hotel room in somewhere in Europe every year, and they name whatever they decide based on the city that they're in. So this was the Lyon consensus, which was not really consensus at all. Across the top, you have different tests you could do to try to figure out, does this person have erosions? Do they have acid refluxing? So the endoscopy, that's where you put a camera down. The pH or pH impedance, you put a little probe that measures pH in the esophagus just above the stomach. And you look at AET as acid exposure time. So what proportion of the time is that little probe being bathed in acid? And then this HRM, that's a thing called, it's a mammometry. It's like a balloon that goes down and looks at if the sphincter on the top of the stomach is opening or closing properly. So you can do a bunch of these tests, and then based on that, on the left-hand side, you'll see the top, sort of higher up, is conclusive evidence for pathological reflux. So like, they definitely got GERD. And at the bottom is, you probably don't have GERD. Now, how many of your patients have left the long-term care facility for one of these tests? Raise of hands. Yeah, other room, I don't see any hands going up. I've never sent someone for, I don't think, for any of these tests. They're not readily accessible. In my community of Nanaimo, we don't have gastroenterology, and I certainly wouldn't send a frail, demented elder patient for one of these tests, right? So it's not practical, and even in well patients in the clinic, it's not something that we usually have access to. So there's not a clear answer there. It's extra complicated in seniors because seniors tend to have less of the common symptoms, so the heartburn, the kind of funny tasting in their mouth, and they tend to have more of these unusual symptoms like horrible crushing chest pain or a little bit sensation, feeling of like something stuck in their throat. I had one patient who had an aspiration event, and later we figured out she probably had a stricture, but that was the first presentation. She probably had reflux going on the whole time, but it wasn't until a very dramatic presentation that we kind of figured things out. Also, older patients, they have more advanced disease. That's just, as you get older, things get more severe in this population, or in this system. And it's also harder to kind of know if you're dealing with GERD because these patients might have Parkinson's or diabetes or something else that makes it hard for the esophagus to move food down or to empty the stomach. And then for your very frail, non-communicative patients like with expressive aphasia or dementia, you have to look at nonverbal signs, so it's extra hard to figure out. And then if you do think, okay, they've got some kind of reflux, it seems problematic, I think we ought to treat them, then trying to make that decision is even harder because those patients have a higher chance of bleeding, they're usually on a whole bunch of other pills, you might have to be crushing medications to get them into them, and they're more vulnerable to the adverse complications. So this is, age is not a modifiable risk factor. I don't know how many of you have had this happen to you. So one of the things that, again, in younger patients, we often recommend lifestyle treatments to lessen the chance of disease. I wanted to look at the evidence for that to see if I should be chasing my seniors around saying, you know, eat smaller meals, lose weight, don't smoke, etc. And of course, most of that's not possible in our population. And when you look at the research, it's quite sparse. There's some thinking that talking, kind of psychotherapy, could be helpful for those people with functional dyspepsia. But we don't actually know. There was a test looking at acid exposure time, was inconclusive. There's some people who swear that if they eat mangoes or tomatoes, it makes it worse. If you avoid trigger foods, yes, you will have fewer symptoms if you're a person who's identified trigger foods. Eating smaller meals, not lying flat, might be helpful for less acid, but we're not sure about symptoms. Losing weight is one of the very few things, lifestyle-wise, that people can do that might make a measurable difference. Avoiding smoking might help with symptoms in a person of normal weight. Most of my long-term care patients don't smoke because it's too difficult for them to get outside to do so. And then lastly, maybe good news for those who like alcohol, if you drink low, moderate amounts, avoiding it doesn't seem to lessen symptoms. If you drink high amounts, it may. So I don't think any of this is going to change my practice with my frail elders. It's just, there it is, okay, meh, nothing that's going to really apply to them. But good to know for if you see others counseling your patients to do those things, to maybe not waste the time on that. So when I looked at the literature about these proton pump inhibitors, I know that they must work, right? You give them to patients and what do they say? Feel better most of the time. Not all the time, but most of the time it's a pretty quick response. And you know, we talked earlier about not being able to do any of those tests that are out there. So for patients where they have GERD labeled by a physician, if you just treat them, it's a pretty good chance they're going to help them. If you treat 2 people, it's like 50-50. One of those people is going to benefit, which in medical care and giving drugs is one of the best drugs that we have. Most other drugs are like, you have to treat 40 people for one person to avoid having a stroke, or you have to treat 1,000 people to avoid something. So treating 2 people is awesome. So I can say, yes, these drugs help people with the symptoms of their acid reflux. If you start doing some investigation, if you've ruled out if you did some of those tests and you ruled out the organic causes, that number is not as good. You'd have to give the drug to 10 people for one of those people to benefit. So you might consider that if your patient's on the medication, they're still complaining of it, maybe they have a very serious problem, or maybe they have that functional disorder and they're just not going to benefit from the medication. When it comes to the more severely erosive and non-erosive reflux, the number is similar. It seems that we can get people's symptoms of heartburn better and we can lessen the erosions in their esophagus. But what's really interesting is even if the scratches all heal up, a person could still have symptoms and vice versa. Their symptoms might improve and the tissue might still be irritated. So those things don't necessarily correlate. And then lastly, in peptic ulcer disease, hard to look at the symptoms there, but we do know that these medications accelerate healing. So they work. So how long should we use these medications in a person? Let's say we don't have any of those tests. They have GERD because they have symptoms of acid reflux, and we're not going to do any tests, we're just assuming it. And no red flags, they don't have cancer or something else. How long should they be on one of these drugs? Room 160, any guesses?
8 weeks.
8 weeks, ooh, nice, okay. Anybody else? 12 weeks. I heard 6 months whispered. 6 weeks.
I got put on them last year and told I'm going to take it for the rest of my life.
I heard, so rest of the life, was that for GERD? May I ask?
Yes, it was because of GERD, but I also ended up with ruptured bowels because I had so much acid. So that's what I was told, and I'm on 80 milligrams a day.
Okay.
And for the rest of my life.
For the rest of your life. So it depends on the condition. I can't speak to those specific circumstances, but really commonly used medication. If you look at the drug monograph, if you look at the specialist guidelines, which are funded by the drug company, and you look at what the Therapeutics Initiative found, we actually are all on the same page, which is shocking. Shocking. 4 to 8 weeks is the general range in which you will see good response. So that number needed to treat of 2 people occurs over that time period. Maybe up to 12 weeks would be, some of the studies were 12 weeks. So great. So if someone has peptic ulcer disease or GERD, 4 to 8 to 12 weeks. People who are treated effectively, though, don't need to continue on it for the rest of their life. And that's the huge gap that we're seeing in BC, is people continuing forever and ever and ever and ever without it ever being asked. So what about, pardon? What about more than 8 weeks? This is where it really gets tricky. So there's some conditions where we said, okay, probably a shorter term, 4 to 6 to 8 weeks would be reasonable for someone who has acid reflux. What might be a condition that you would treat for life? Barrett's esophagus, right? So that's the kind of precancerous or cancerous, beginning of cancerous change to the esophagus. Yeah, that's a great example. Some of those hypersecretion states where a person has a tendency to overproduce acid, that's been verified through some of those tests. People with really severe esophagitis, probably, and that's actually what our first TI, our third TI letter said. There's some kind of in-between areas, though. So bleeding ulcers, depending on the circumstances, if it was a person who had alcohol misuse and stopped drinking alcohol, they probably wouldn't need to continue on that PPI. So if there's reversible factors, which often is the case in our frail elders, everything has changed for them, and a lot of the risk factors that might have been present there, like using NSAIDs and things, may no longer be on the table. When it comes to that middle ground, you see I've put there the NSAID drugs, so that's like aspirin, ibuprofen, naproxen, medications that our frail seniors may not be on. Some of them are on prednisone, which is a steroid, some similar difficulty with erosion of the lining of the stomach. A lot of physicians will prescribe an anti-inflammatory along with a proton pump inhibitor. The idea being the proton pump inhibitor will reduce the acid in the stomach, which will prevent some erosion of the mucosal lining, because being on the NSAID increases the degradation of that lining. But thank you to Kate. I borrowed some numbers from her crunching. There have been a few studies on this, but none of them were very helpful at first. So in 2002, Cochrane did a review about proton pump inhibitors and NSAID use, and they found a few trials, but they didn't look at things that patients care about. So my patients, they say, well, am I going to die? Am I going to bleed and need to have blood transfusions? Am I going to have to go to the hospital and have a surgery from a perforation? They care about those things. They don't really care what, if we put a camera down there, what it would show, because that doesn't matter to them. It's more about their quality of life and what is entailed there. So looking for ulcers, do PPIs prevent ulcers? Yes, in terms of their rating on endoscopy. But that wasn't quite helpful, because I think we need to look a little bit further. So Tran Doi in 2015, the group did kind of reanalyze some of that data and included a couple of other randomized controlled trials, which again showed the same thing, that treating patients on NSAIDs with a proton pump inhibitor lessened their chance of these ulcers. And bleeding, they looked at it. The interesting thing is most of the studies that they looked at were not randomized controlled trials. They were cohort studies. They were studies done for other reasons. And so the kind of researchers looked back to see if they could find these things. They weren't really designed for this. There was a couple of randomized controlled trials that maybe showed some benefit, but then when you look at the lines that go across, I don't think I don't know if this is the laser pointer, and I'm sure in 160 you won't see it, so I'll just try to describe this. So there's highlighted Yaumans, so there's a randomized clinical trial there, and that line shows the spectrum of truth. So somewhere between those ends of that long line is the truth. And where the dotted line is, that's a sign that if a person is on a proton pump inhibitor versus on placebo, at that line, there's no difference in the results. So if the spectrum of truth crosses that line, it means that the medication may have had no effect whatsoever. So both of these randomized controlled trials didn't convincingly say that these drugs prevent bleeding. But that wasn't really that helpful. So it's 2019. We could do a longer, better trial. We could have a look at this. So Moyadi et al., this is a Canadian-based group that built onto another trial. There was a COMPASS trial, which was people on who were randomized to aspirin or rivaroxaban or both medications for prevention of issues related to their coronary artery disease and their peripheral artery disease. So fairly sick people, not living in long-term care homes, outpatients. So they were put on those blood thinners, and then they were further randomized to receiving one of these drugs, pantoprazole or nothing. It was sponsored by Bayer, who make aspirin, and the average age was 67, so seniors population. But what was interesting is they tried to do this composite event of things that they thought mattered. So they were looking for, if a person was on the proton pump inhibitor, were they protected against bleeding from their upper GI tract, which was like vomiting blood or occult, so detected in the stool. They were looking for symptomatic ulcers. They were looking for people who on endoscopy would have more than 5 erosions, a blockage, which is what my patient wound up having, or a perforation. And they found there was actually no difference in these patients. And then they thought, well, let's just look at bleeding because people care about that. And they found, yeah, there was a slight difference. The people on pantoprazole had a less chance, but you had to give that drug to 1,770 people for a year to prevent one person from having a significant GI bleed. So that's like 4, 5, 6 nursing home facilities that everybody would have to have the drug on these blood thinners to prevent one event. So that's a lot of people. They kind of massaged the definitions to try to get a better number, and even when they did that, it's still almost 1,000 people you'd have to treat. So this didn't make the case for putting people on PPIs if they're putting on NSAIDs, and including aspirin as NSAID or on these DOACs. So just something to think about. Not our patient population specifically, but it's the closest thing that we have. Okay, so we've talked about proton pump inhibitors, starting to talk about when they're needed, when they're not. We know that they work, so why don't we just keep them forever if they work pretty well, 1 in 2 chance of them working for you? Well, the problem is that there's some bad stuff that happens in people who are on PPIs. Which of these is not a known harm associated with proton pump inhibitors? What do you think? Hearing some D's, some B's. 160, any thoughts? C? Everyone's shy. Okay, it's complicated is the right answer, which is F, I guess. The thing is, what I'm going to be talking about are associated harms. So there's no long-term randomized controlled trials that look specifically at the harms of these drugs. There's randomized controlled trials that mention the harms, but they weren't really powered to look specifically at those. There's observational studies, huge ones, but those are looking backwards, or they're kind of massage the language to look. So we really don't have great information about this, but the consensus is that bad stuff seems to happen more in people who are on PPIs. And there may be a bit of a confound there, right? People who are sick with other illnesses are more likely to get put on a PPI because maybe they go to the doctor more often, maybe they have other drugs they're taking that cause heartburn, that then they're put on other things. So we can only say that there's an association. And I'm going to show you some of those. Now this is a really busy slide, and I don't think you have to know any of these numbers or anything. I just want to tell you there's a whole bunch of bad stuff that happens in patients who are on these. And some of them are probably more believable than others. Now I stole this from a paper where they basically on the left up and down axis, they looked at sort of the quality of the evidence. So if there's like huge systematic reviews full of good randomized trials, that would be at the top. And if it's just like a case report, that would be at the bottom. And then effect size is sort of the magnitude of badness. So if it's more on the left, that would be like, this maybe increases your risk a little bit. And on the larger side is, okay, there's like quite a multiplier here. If you're on the PPI, you're a lot worse off than the control group. So pneumonia, I remember not prescribing or taking someone off PPIs because I thought it increased their risk of recurrent pneumonia based on some paper I read some time ago. Looking back at it, probably that wasn't real. It was probably that patients going into the office had a cough. They were given PPIs thinking it was reflex kind of effect, and it turned out actually it was just the beginning of pneumonia. They went on to develop pneumonia. So that one is not that convincing. Bone fractures, we're seeing a little bit more about this. I'm working with the GPAC Osteoporosis Guidelines Group, and this is something that's come up in our survey of the literature. So the odds ratio is sort of like a multiplier of compared to not being on a PPI. What is, if you're on a PPI, your chance of getting a fracture? I think for hip fracture is 1.25 times versus 1.5 times. And for those who are statistics buff, you'll notice I mix odds ratio and hazard ratios and things. I'm not going to get into the details of that because I don't think the numbers are so important as just understanding the kind of different potential things that are associated. So some vitamin deficiencies could be related, hypomagnesemia and B12 deficiency. So it might be the case that you have a patient that needs to be on a PPI for their hypersecretory condition or the Barrett's. That's okay, but if they have a tendency to hypomagnesemia, or you notice that their hemoglobin is decreasing, or they're having numbness and tingling in their hands, you might consider having a look at that value. It's not that everyone on a PPI needs a vitamin B12 test. I certainly wouldn't recommend that. But just in the back of your mind, if you're thinking like, oh, you know, there may be an association there, it's something I need to keep an eye on. Cancers, there's an odds ratio increase of 2.10, so twofold chance of gastric cancer if you're on a PPI. Now, is that because these people have symptoms of early disease and they get put on a PPI to treat that? The literature suggests it's probably more of a robust effect than that, because a lot of those type of patients are screened out of clinical trials pretty quickly, but it's something to watch for. Spontaneous bacterial peritonitis. So for me, so the hazard ratio there depends what you look at, somewhere between up to 5-fold increase. So this is your patient who has ascites. They got fluid in their belly, maybe from liver failure, from a cancer, something else. Their chance of spontaneously developing a bacterial infection in their belly, which really hurts, is much higher if they're on a PPI. Now again, I don't know about confounds there, but this is something where I'm thinking that's a pretty strong association. I might hesitate to prescribe a PPI. Maybe I would use like something like ranitidine instead, or maybe I'd think twice, do they really need that if they're already on it? And C. diff, you've probably all heard of that, and like the fear struck into you, the person who came back from the hospital who was on like 6 years of IV antibiotics, who's also on a PPI, that might be a good person to take off the PPI if they really don't need it. And then there's this other swirl of stuff where we're seeing the evidence is strong, but we don't really understand what it all means. There's tons of emerging evidence about how the bacteria in our guts have to do with our overall health, but we don't really get it. So SIBOs, like small intestine bacterial overgrowth, which seems to be definitely a thing that happens, but we don't really know what it does. There's things like polyps that can occur that probably don't mean anything to patients. They don't cause any harm. They're just there. But if they get a scope and a polyp is seen, then they're going to keep getting scoped all the time to monitor that. So I don't think that would change your practice. One that did change my practice is the fundic mucosal hypertrophy, which means sort of in this case, it's the goblet cells that produce the acid more to the top of the stomach. They tend to overgrow if a person is on PPIs. So if they're on the PPIs and that's happening, you will find if you try to reduce the PPI, they may have a rebound issue with increased acid. So that's really important, and I'll talk about deprescribing shortly. So those were all of the kind of harms that are associated with the acid-reducing effect of the drug. Now the molecule itself does some other weird and wacky things that we're still figuring out. Increased risk of dementia, maybe. And well, That could just be that people are getting put on this drug, I don't know. But there is this proposed mechanism that PPIs may indirectly cause a buildup of some of the fibrillar A thing, this tangle that forms in Alzheimer's dementia. So there might be some perceivable mechanism there. Cardiovascular disease, so heart attacks and strokes and other measures of it, depending on the paper, relative risk of 2.3% or 2.3-fold. So again, an association that we have to tease out. I think that's compelling enough that we need more long-term RCTs to see, is this a real thing that we have to worry about? Kidney failure. So in the hospital or in the clinic, long-term care facility, if you have a patient who is put on one of these medications and they happen to be having lab work maybe every 6 months or 3 months to monitor their kidney function because they're on a bunch of other drugs, and there's a sudden change in that and they've just started PPI, that might be something to keep an eye on. Collagenous colitis, which I won't go into, is not well understood, but there's a fairly strong association there in terms of that. Drug allergy is something that any drug can have, of course, and so we're pretty sure of it, but it seems to be relatively uncommon with these medications. One that's concerning that's not very well known is the interaction with clopidogrel or Plavix, which is the medication we usually use as a blood thinner after a stroke or after a stent is placed. I think a fair number of long-term care patients are on that. And the FDA has a specific warning to 2 of the PPIs, omeprazole and esomeprazole, about this because they alter the liver processing of pantoprazole, which can result in decreased levels of the effective metabolite. So these patients, they may be on Plavix, but it's not actually working in the way that it's supposed to prevent their stroke, so it renders it ineffective. So that's really important to note because a lot of those people wind up on PPIs just in case they bleed. So that's the kind of person that could definitely come off, or could be definitely considered to come off their PPI. And then decreased life expectancy. Let's tease that out a little bit further. So this is in an upcoming number 126 therapeutics letter, should be released within the next few months. And we looked at some studies that looked at death within at least a period of at least 3 months of PPI use. So the first one was that same one I talked about earlier, so the extension of the COMPASS trial. That was the sort of, do PPIs protect against bleeding and people take blood thinners? And there was a slight increased risk potentially, but it wasn't significant. You see that it's a lot of stats jargon, but in that third box where it says hazard ratio 1.03, that's pretty close to 1. And the number there, the confidence interval, is sort of the ends of what could be real. So between 0.92 and 1.15. So probably not an increased risk of death in that trial, which was up to 3 years long. And the average patients were, I think, 67 in that trial. The next one was a huge study. This was like 100,000, more than, 157,000 on PPI and 56,000 who were on like H2 receptor agonist, like antihistamine, like ranitidine, and they compared people who were new, they were started on the PPI or the ranitidine going forward, and they covered them for 10 years, and they found there was definitely an increased hazard ratio in the group that was on the PPI. Now, we don't know what influenced the choice of the doctor or prescriber who put them on the PPI versus the H2 blocker, so there could be some confounds there. But that's concerning. That's 45 extra dead people per 1,000 on the drug. So that's not a little blip. That's death. And in that study, that quote at the bottom comes from there. They said, heightened vigilance in the use of a PPI may be warranted. And then there was another systematic review and meta-analysis that included 3 observational studies on mortality, and it also showed even a higher odds ratio, 1.68. So more information about that will be in the therapeutics letter, which if you go to ti.ubc.ca, you can subscribe to it digitally or ask Alan how to get a paper copy. So we can't confidently say any of those harms are caused by the PPI. We can't. The science doesn't allow it. But there's some weird stuff, worrying stuff there that's probably strong enough to say, hey, if a person is on this for more than, what do you guys said, 4 to 6 to 8 to 12 weeks, and it was for GERD and not one of those long-term lifelong states, maybe we should take them off it. But one of the challenges is figuring out why they're on it. So this is specific to long-term care residents. I want you to guess what proportion of people in long-term care residents have no documented indication. So we don't know the diagnosis for the PPI. What do you think?
52.
Ooh, go 160, room 160. 52% of people, no indication. D, 34. B, 18, okay. You're gun shy because before you were over, now. Is this the, I don't know if we're playing by Price is Right rules here. So the answer is actually 34%. So this is, so they're on a drug and we don't know why they're on it. They can't remember, their family can't remember, it's not documented. The physician doesn't know, the pharmacist doesn't know. So these are the patients where if you're the nurse, you're like, what is Jim on this for anyway? That's a perfect opportunity to kind of lean in. If you look at other studies, the rates in outpatients are higher. Is this because doctors are lazy and don't want to type in the diagnosis? Maybe. Or maybe it's because they've just been on it forever and no one ever thought to ask who started it. I'm a doc, I can flag myself up. But, maybe these people have just been on it forever and no one ever asked because it's a benign drug, right? Or it was before we started looking at some of the long-term associations. So I think what happens is people get put on it and we've been put them on it, they get better and like, cool, we'll see you in 6 years, and they just stay on it forever and ever. And once people are on it, it can be hard to take them off because they're like, hey, it worked. It's so good. I got no more heartburn. I can eat as much at Thanksgiving as I want. So you may not want to touch that because it finally works. But even the gastroenterologists and choosing wisely calendar are saying, don't maintain it for symptoms unless you've tried to stop it at least once a year. So if Betty's been on it for 6 years since it was on her intake list when she came in and it's still on there and we have no idea why, that's time to have a conversation about maybe trying with less. And this is a younger population, it's people under 65. This will be in our next letter. But just showing that young people wind up on it over 5 years. Almost half the people who get PPI were on it for that long. So it could be something that's carried on through their time before they wound up in the facility, and no one thought to ask. Okay, so how do we stop it? Well, some of you will know that song, Breaking Up is Hard to Do. As long as I live, I guess that's another track. Don't know how that relates. I guess if it really is a mortality issue with PPIs, we'll be hearing more about that. It can be really hard to stop these drugs for all the reasons that it's hard to stop any other drug, and some unique ones to PPIs. So what do you think is the best way to stop these? C, tapering. D is alternating. Tapering. We've got room, yeah, okay. Tapering. Room 160. So everyone is tending towards C. Okay. Good questions. B, some patients will say B. So we don't know for sure what is the best way, but we know a little bit about what happens when you try. And there's some really good resources if you're aware of deprescribing.org. In your package in front of you, there's an algorithm that has all of this information there if you're interested, because it can help prompt the questions. And they looked at all the literature about how you might stop these, and they found that, probably reducing the dose is one of the easiest things to do. With the least number of ill effects and reemergence of symptoms. One of the troubles in BC is that the pantoprazole magnesium, which is covered, the government would only pay for the 40 and not the 20, but you can certainly decrease the dose, even if the monograph says you can't break it, you can break it. Another option was changing to intermittent use or on demand, which is something I really like in my residents, so that if maybe I've decreased the dose, they're still on it, I don't think they need it, there's no clear indication, we can switch to, and I'll just say, daily PRN, so that the nursing staff can use it at their discretion. I think when I was a med student, Kate, when she was training, we both had this experience where we were teaching everyone, like, no, you have to take it every day. Oh, your symptoms are back because you didn't take it every day. You got to take it every day. That's how it works. Actually, there's no harm and probably some benefit to taking it on an as-needed basis. You can use it during periods where you're more prone, so over the Christmas holidays where people are eating more, that kind of thing, and then they can stop it. And as long as they don't have symptoms, that might be a great way to reduce the use of it and lessen the chance of some of those associations. You could stop cold turkey that may be a little bit harder. And then the evidence suggests that substituting something like ranitidine would be reasonable, although I know we've had some access issues to that lately, so that may not be a realistic option for us right now. You have this algorithm in front of you if you're interested. You'll see that what they say is a little different than what I have said, but I think it's still a really good tool for just prompting that conversation. Like, number one question, if you take away nothing else from my talk today, why are they taking this PPI? Why? They might really need it. No problem. They might find it really helpful. Okay. Do they know there's some associated harms? Does their substitute decision maker know some of those harms? Are they concerned about them? Are they not? Maybe it's all about quality of life, and if she gets C. diff, we'll just deal with that when it happens. That's fine. But having that informed discussion, starting with why, is very helpful. And you might see something on here that just makes you think of a specific patient, like, this person had a really big problem, but it's really settled down now. I wonder what would happen if we change that. So it gives some ideas about how you might do that. And there's handouts that you can give patient families and other tools on the website. I think I'm going to skim over most of this, but basically it's what I said earlier, is that if you stop the medications, there's no evidence of serious harms from happening. We do know that people will have some symptoms or may have some symptoms when they stop or change or decrease. So just advising people of that, I'm going to expect that you're going to have this. Let's use it on an as-needed basis after we stop it, so you have the power that it's whenever you need it, you can ask. And then maybe limiting that is an easy way to get people off of it. It's very rare with my patients that they've needed to go back on it regularly. I still have some patients where I've deprescribed it and they're just using it on an as-needed basis. If you need more help, there's also a really good video of how to use this algorithm on the website, and I think these slides will be sent around or posted on the Long-Term Care Initiative's website after, so you can click the links and check it out. I think we're about on time for questions. I think we're 7:05. Yes. That's been a whirlwind tour of deprescribing. I think I just have one last slide to kind of sum up what we learned, and then we'll open it up to any other thoughts, worries, questions, cases. So like I said before, the first thing is thinking about why. Why is this person on a PPI? Probably prescribing it 4 to 8 weeks. If they're on mild things, makes sense. If they have red flags, if they're losing weight, if there's other things going on, if they've got frank bleeding, those are scary things that might need further investigation or at least discussion about goals of care and how to proceed. If a person isn't improving with the treatment, it could also be, rather than something big and scary, it could be that functional side of things. So maybe they could benefit from other treatment of other things that we haven't really figured out what the best treatments are for those, but if they have a concomitant anxiety condition or something else, that might be worth exploring. There's some people who need longer-term treatment, and that's great, but those people will all have had investigations to prove that they need it. It's hard to be confident about discussing the harms of these medications because we don't really know what they cause. We know there's a lot of associations, and there's going to be more studies about that, but I think it's compelling enough to say, if you've got residents who are on these and we don't know why, maybe that's something you flag to the physician, or as a physician you think, okay, let's try off of it. Worst case scenario, we have to restart it. Cool. That's easy to do, but it's so easy to reduce a person's pill burden and to potentially lessen some of serious harms, including death, and some things that would really disrupt their quality of life by reducing. And then lastly, if you're doing some deprescribing, we're still going to ask, why do they need it? How do we know that? And we can try any of those methods, reducing the dose, switching to something else, switching to PRN. And you can dose it regularly. Often I'll do that every second. If a person's been on a high level, like 80, bring them down to 40, 20, and then maybe every second day. I know that doesn't say that in the monograph, but a perfectly reasonable way to do it so that they have fewer symptoms as they're reducing. And just warning about the rebound, I think, is helpful. So I'd love if there's any questions, difficult cases, things that you disagree with or you want to know a little bit more. I think we've got 10, 15 minutes, and then the break's at 7:20. Room 160, any worries, concerns, questions? I'll just give them a minute first and then I'll look to this room. Wave your hands wildly in room 160 if you have something to say. Okay, I don't see that, so we'll start here.
I'm just wondering, my understanding was the PPIs don't work if you're using a PRN as the H2 blocker, but I'm not sure that's true. So I don't know what the speed of action is for PPI.
I haven't seen that. I don't know, Kate, if you know that offhand. I haven't seen that in an RCT.
There are studies using them dosed PRN, and I don't know if you have family members who use them PRN. Yeah, they work that way for sure. Yeah, better again. My question.
Yeah. In terms of the mechanism of action, I think the half-life of the H2 blocker is shorter because they don't work very well for the nocturnal symptoms of GERD. That part I'm familiar with. But in my scouring of RCTs, I didn't see anything, and in the deprescribing literature, there's definitely a difference in sort of efficacy in terms of relieving symptoms. The number needed to treat with the H2 blockers can be 4 to 10, depends how they do the study, but more will need to be on it for somebody to benefit. But I'm sorry, I don't know for sure about how quick it kicks in.
The studies have compared them in terms of when does the pH change, and it looks like H2 blockers are faster, but they haven't really compared them in terms of when do people feel better. So I think it's hard to feel strongly, but I mean, working in pharmacy, people would just say, you have to take it every now and then, and it works. And then the study supported that.
So for room 160, if you didn't hear, Kate was just saying, Kate O'Sullivan, who will be up next, was just talking about the studies show differences in how quick different medications influence the measured pH. Not sure about symptoms, but there's good evidence that using them on an as-needed basis is a reasonable, appropriate, and effective for relief of symptoms. Yeah. Can you press your button, please?
Nothing.
Okay. I'll repeat the question.
Don't take it unless you get pain. So if I just use the analogy of what we do with analgesics, we don't do that, right? We acknowledge that we give regular analgesics if you don't want to be always chasing the pain. So it's an interesting thing to ask the patient when we take this as a term.
So this is. Depends on the patient. So just repeating the question for room 160, the analogy being with pain, and as a palliative care doctor, I'm quite familiar with that approach, that we treat ahead. We want to stay ahead of the pain, and so that a person isn't disabled and in a kind of crisis and needing rescue from that. And absolutely I agree with that for pain, but usually my approach to pain is when they first have pain, we treat it PRN. If it becomes a chronic problem, if it becomes really bad and it's not responding to, like, once every few days they need a little bit of Tylenol, or we escalate, they need a little bit of hydromorphine, then yeah, they wind up on something longer acting. And I think the same approach would be reasonable for these patients. It's all about risk and benefits, right? There's tons of risks with opiates and escalating doses, but sometimes those are worthwhile for the benefit. And I think the same is true of PPIs. If a patient's like, I love it, it works really well, there's no way I'm coming off of it. Okay, well, we're just going to watch, and if there's any of these associated risks, then maybe we should have another conversation. Maybe next year we can try again. Or would you be willing to try reducing the dose for time, see how that goes? Well, we could do it on an as-needed basis for a week or two, and if you think, oh my God, I need this every day, we'll just start it up again and we can try again later. I don't think there's harm in any of those approaches. It's more about having the discussion that probably not a benign drug, and maybe easy to get off if we coach and prepare and we use some of these gradual ways to do it. Yeah.
Let me have any suggestions for patients who are long-term care residents who are non-verbal. I worry that I'm going to take them off and I'm going to suffer and not know.
Yeah. So the question was about long-term care residents who are non-verbal and worrying about if I take them off the drug, maybe they'll suffer and I won't have any sign of that. I don't know if you in your facility use scales like Pain AD and other tools to rate signs of distress. It can be really challenging with acid reflux to figure out, is that what's causing the problem or something else? But I also know in patients who especially with advanced dementia who are nonverbal, there's a few different things that happen in those patients that make it even more complicated, like recurrent aspiration pneumonias, for example, and difficulty swallowing. So my discussion usually with the family is to say, there's some risks and benefits. She has a really hard time swallowing pills, so I think it would be nice if we could reduce the pill burden. So this is what I'm proposing there. However, if we see facial grimacing, if she's gesturing towards her chest, if there's these other signs, we might consider that. If she's got a new cough and so on, you could treat as needed. I think it's a very individual perspective. Do the harms outweigh the benefits for that person? I mean, if they had terrible symptoms and they've just started recently, then it's probably something I would continue. But it's that individual. That's why this algorithm, it's just sort of a thought-prompting exercise. It can't really inform for the individual patient. But I agree, it's a huge challenge. And because older patients tend to have those not typical symptoms, even if they can express them, they might experience things in different ways. So it can be really hard to assess. There are, not that I reviewed in this. I don't think we have a letter. We have an old letter on H2 blockers from a long time ago, but it was all about efficacy. I don't think we've delved into the data there. There's certainly some of the harms that are associated with the reduction in acid. I would expect that those would be probably not to the same magnitude. I don't know if I can go back all the way there. But the ones that are associated with the specific molecule and the other weird and wonderful things that it causes probably would not occur. I'm sorry, I've looked at that, but it's sort of like I've read this paper and that paper. I've not done a systematic review, so I don't think I give you a fair answer. Maybe Kate can add. Yeah.
When we did the topic in academic detail, it was definitely.
So Kate, for the other room, Kate's just saying when it was because she works as a academic detailer as well, that the research, there's a paucity of evidence in that area, and certainly not a huge focus, probably because the rates of use are so much lower than PPIs now. I think we have time for one or two more questions.
With regard to recurrent symptoms, at what point do you be fairly certain you're past that rebound stage?
Depends. So weeks at least. I think I saw a pretty huge range. Some papers days, but I think 6 weeks was the outward end of the hypersecretory that in the kind of these studies that I looked at. Yeah, and using that PRN is reasonable. Yeah. Sorry, the question for 160 was about the duration of rebound hypersecretion and symptoms when you're withdrawing a patient off the medication. Any questions in room 160? Give you a minute. You can run over here and wave at me frantically in person, or you can wave your arms there. I don't know if the mics are working. If they're not, we'll definitely address that at the break, and you can come find me if you want to chat. So we're going to just see if there are any other questions. I hope it's somewhat helpful for just looking at this with a little bit more detail in your patients, seeing, hey, are they on this? Do they really need to be on it? Maybe they do, maybe they don't. But even thinking of that and having a conversation and prompting some members of your team. And like I said at the beginning, one of the most effective interventions for these patients, which it may appeal to some, but it wasn't a cost-saving initiative, but it happened to do that, was a pharmacist working with the nursing staff to identify, okay, here's all the patients who are on the drug. Now I'm going to look at every single chart, look at, is there an indication? And I think in this case it was worse. It wasn't 34%, but that was even higher. And if there wasn't, trying to figure out what it was, talking to the family, reviewing the hospital notes, whatever. And then if nothing could be found, faxing the physician's thing. Would you consider any of the following? Reducing the dose, alternating days, or stopping it altogether, or switching to ranitidine, and allowing the physician sort of one of those choices. And you can make a huge difference to the amount of medications that your nurses have to administer. So just a thought there. If you want, you can come find me at the break. Alan has some of our TI letters if you're interested in reading a little bit more detail about some of the studies that I talked about and some of our perspectives. And we've got a break until 7:30, and then Kate will be talking about vitamin D.
All right, I'm gonna go see someone. It's Mike. It's yours. Oh, it is here. I just kind of It's on the desktop. Yeah, I was gonna say. Yeah. Second row, that first light, the light. That's what we're waiting for. Yeah, exactly. What do you think? Ready? What do you think? I don't know. Or, yeah, well, 45 plus question. Yeah. Hard to do in practice. In some ways, but in other ways, like once you're doing it, it's like a hobby for me. Like, oh, what are you on? Oh, I can stop. Oh, put it back on. Yeah, but it's, I mean, you have to have that courage, and I didn't realize how many nurses get really good because they're the ones who do so much. Last year was
the question I had almost as expected was I usually have this talk in emergency. But all my patients, a significant number of my patients come back. Why do they do that? No. I just can't, I don't know what it is. Really? All the, everybody was just saying that.
And then you walk.
Yeah. You do that. Yeah. But you're ahead of us. Moving on, let's say, yeah, we still have a lot of people coming back. And it's usually whatever is top of PPI at that hospital. That's right. That's right. But in hospital, all PPIs are paid for. They come to us and we're going to do special.
Is this on? Can you hear me? Okay. Yeah. Are you guys ready to get started? I feel really loud. That feels really loud.
Hello? Can everyone please come back and take a seat? We're about to start again. All right. Thank you. Hope you got some good treats and something to drink. All right, everyone, we're about to get started. Everyone can just turn your attention to the front. Everyone tap a neighbor.
Is this okay? Loud enough? Good. Okay, I'm going to get started because I'm usually in bed by 8:55, so this seems terribly late to be presenting, working, and I don't think it will take more than half an hour because it's just vitamin D. So this is just some evidence to support individualized decision making. So I'm a pharmacist with Island Health and the BC Provincial Academic Detailing Service. Has anyone heard of the PAD service? Cool. I also work half a day a week with the Therapeutics Initiative, and that's where all of the money I earn comes from. I have some more disclosures because after I present on vitamin D, I often get emails to the effect of, why don't you like vitamin D? And I just want to make it clear, I don't feel strongly about it. I'm not even passionate about it. I only do this presentation because we get asked to. I get probably more emails about vitamin D and the evidence for that than anything else, more than statins, more than type 2 diabetes. So this is just some information that I found. So there's that. I did co-author a letter objecting to order sets prescriptive of high-dose vitamin D in long-term care. That was in 2012. And then I just work academically now. When I worked as a clinical pharmacist, it seemed to me that our long-term care medication reviews spent a lot of time talking about calcium and vitamin D, and we spent less time talking about more essential medications or potentially more harmful medications. And I'm guilty of having contributed to that imbalance, and that haunts me to this day. So vitamin D is kind of curious though, right? Because you probably have had people say things like this to you. So from a family practice resident, I'm all about the vitamin D. From a nurse, I take vitamin D because everyone in the hospital is on it. I speak at an osteoporosis support group where a woman said, my 4,000 units seems to be working. From a friend, vitamin D is really helping with my perimenopause. And from a really close friend, and it was actually kind of shocking to me that I didn't know she was taking 8,000 units. She said, as we were drinking a margarita, I'm only taking 4,000 units now because my levels went too high on 8,000. From a mountain biking buddy, I'm not riding well today because I forgot my vitamin D. So have people said things like this to you in your life? So I thought I would just look at a few things. Are most of us suffering from vitamin D deficiency? What does taking a supplement do anyway? And important to you guys, I think, how well represented in the trials are people who live in long-term care? And what happens if we just give more? And just sit back and relax and know that the most important thing you could read is this BMJ review of vitamin D that's printed out for you.
There isn't a therapeutics letter on vitamin D, and I don't think there should be because I don't think anyone could do a better job than this summary. I also should warn people when I present, I never have a conclusion slide. So don't expect that at the end it's going to be wrapped up with a little bow. I just hope that one or two things during this presentation matters to you. And if you forget any of the science, just know that it's in this review article. Okay, so are most of us suffering from vitamin D deficiency? So to address this, I went to a vitamin D guideline, a draft, just last year, and it says, when vitamin D is measured, the optimal concentration for bone health is agreed to be at least 50 nanomoles per liter. So that infers we should have, all of us, levels of 50 nanomoles per liter or higher. Is that how you read that? However, others recommend 75 to 125 for general health, that that's the optimum range. So I have searched for a review of vitamin D levels that are not paid for by people who sell vitamin D tests or vitamin D supplements, and it turns out that's hard to find. There was this review in 2011. It's about 1,000 pages long, and no one ever asked me to send it to them. I can. And it was a review committee of 14 scientists. It was requested by the US and Canadian governments to inform on dietary reference intakes for calcium and vitamin D. And so in reviewing the literature, what they determined was indeed vitamin D is important for skeletal outcomes, particularly for preventing rickets and osteomalacia. So often when I present, people will say, you said vitamin D is useless. No, vitamin D is an essential nutrient for preventing rickets and osteomalacia, and evidence was a little bit less convincing for osteoporotic fractures. But what they determined was if at the population level, levels less than 30 puts people at risk for deficiency, and that is important. 50 nanomoles per liter, they judged that most of us, 97.5% of the population requires less than 50. So that's a little bit different than we need 50 at least, right? Do you see the subtle difference? 97.5% of us require less than 50 nanomoles per liter. And they estimated these, and this translates later into recommended dietary intakes. They made these estimates under assuming conditions of minimal sun exposure. So thinking about people we're most worried about, people who live in long-term care, people who live in the north, etc. And sort of what I call the clinical bummer is that you can't then say an individual person's level should be this. Like this is all at the population level. They say it's impossible to know an individual patient's actual vitamin D requirement because the reality is we probably all need something different. So that's why guidelines aren't typically saying you should test everyone and treat to a specific target because the evidence isn't that as precise as we would like. So they said 97.5% of the population requires less than 50 nanomoles per liter, which you agree is a little bit different than what this draft guideline is saying, where they say we need at least 50 nanomoles per liter. And this becomes important when we think about how much should people take. They also looked at, they were aware, this committee of scientists, that there was a lot of advocation for higher vitamin D levels. So this is just an example. Osteoporosis Canada in 2010 said desirable vitamin D status is above 75 nanomoles per liter with a very low quality of evidence, 3. 4 is expert opinion. So it's just, you know, shoulder away from expert opinion. But I think this translated into many lab reports. If someone was less than 75, they were defined as having vitamin D deficiency. So they looked at achieving 75 or greater, and they determined it was not consistently associated with increased benefit. And then they looked at above 125 and found it was associated with a risk of adverse events, hypercalcemia and nephrolithiasis. So you might remember that draft of the guideline was kind of suggesting getting people up to those levels for optimal health benefits.
So the draft of the guideline says, during the Canadian autumn, winter, and spring, the adult population is unlikely to achieve adequate vitamin D levels through diet and sunlight alone. And I just thought this was kind of cute. Family practice resident said, yeah, we're suffering from low UV. Thought it was cute. You know, I've got low UV. And the reference that the draft of this guideline was using was this study, a survey from Canadian Health Measures. They said, did a survey of blood concentrations of Canadians. 68% were over 50, so they were reporting that a third were below the cutoff. You seeing any issues here? So the Committee of Scientists with the National Academies have talked about this quite a bit. This misapplication of the 50 nanomoles per liter, it creates the appearance of a pandemic of deficiency, and it's a problem because most of us require less than 50 nanomoles per liter. So saying a third of us are less than 50 isn't really defining us as having a pandemic of a deficiency. And they looked at surveys, Canadian surveys for all life stage groups, and it suggested that requirements were being met because we were on average above 60. They did look at, so remember the National Academies, the Committee of Scientists said yes, less than 30 nanomoles per liter puts population at risk for deficiency, and they did break it down by season, and like summer versus winter, and in the summer, 6% of Canadians were less than 30, and in the winter, 15% of Canadians. Oh, just a mountain biking buddy. I've got it really bad in the winter. Thought that was cute. So what are your thoughts? 15% less than 30 in the winter. Important? Pandemic? I don't actually know what the definition of when it achieves pandemic levels. So one thing I hadn't thought of, and one of the authors of that earlier Osteoporosis Canada Vitamin D guideline, in one of his presentations, he says it's kind of an unanswered question, like is this seasonal fluctuation even harmful? So if I'm a little bit lower in the winter and higher in the summer, like does that really put me at risk? And it's, I had really bought into this, we've got it really bad in the winter, but it's kind of unanswered as to whether if we're a little bit bad in the winter, whether that really puts us at an important risk. I went to something a little more contemporary to get a sense of are we all deficient? This was, and I'll show you the results of it, a high-dose vitamin D study published in JAMA in 2019. It was from a single center in Calgary. And it was funded by Pure North. It's this clinic in Calgary, I guess a longevity clinic, feel better, live longer. In a sort of unrelated story in 2017 on CBC, they had said in Alberta we're all deficient. And if you go on their website, they'll say world's leading experts suggest optimal levels are 100 to 175 nanomoles per liter. It's a little bit discordant, hey, from what the National Academies found. So in this single center study, again, I'll show you the results in a little bit. So thinking these are probably community dwelling ambulatory Calgarians. The average vitamin D levels at baseline was 80 nanomoles per liter. So is that screaming to you that we are all deficient? And I don't usually look at these flow diagrams, so it was just kind of interesting to me. This is why they excluded people. And they excluded 35 people because their levels were too high, actually using the National Academy's definition of above 125, and just 6 people were excluded because they were too low. So it just makes me think maybe we're worried about the wrong thing now, given friends of like mine are taking 8,000 units, right? So the next question, what does taking a vitamin D supplement do anyway? Do you guys have a good handle on what the evidence is if we ask people to take a supplement? Sorry, which outcomes it improves, or does it any? Sorry. Anyone? So I'll just explain that So my interest is in the randomized control trials when we actually test, does having someone take a vitamin D supplement improve outcomes? You might know that if you Google, is vitamin D linked to, you can find observational studies linking it to everything. And I'm not going to look at that literature, but you can find it, honestly, you just vitamin D and whatever disease state, and you'll find a study. These observational studies are a little challenging to interpret because they include the possibility that vitamin D deficiency is the result of the medical condition and not the cause of it. So the literature I'm going to show you is testing what happens to outcomes when we ask people are randomized to taking vitamin D. So remember the draft of that guideline said, you know, we should maybe achieve higher levels for general health. And so this study was actually looking at that. It was just published last year. And you can see that there was a lot of hope that vitamin D would improve health outcomes. It was a vitamin D trial giving ambulatory Americans vitamin D 2,000 units daily for 5 years. And the National Institute of Health was sufficiently convinced that they invested $22 million US in this trial. And so at baseline, people's vitamin D levels were 74 nanomoles per liter, and the 2,000 units got them into that pretty decent general health range, right? And these are the outcomes they looked at, whether giving vitamin D improved, reduced the risk of any invasive cancer, major cardiovascular events, or improved survival. And you might know from Jessica's talk that if your hazard ratio or your point estimate is 1.00, it means your intervention hasn't improved that effect, improved that outcome. So what do you guys kind of see here for hazard ratios? Is it pretty much ones all the way across? So this was the big trial testing, does vitamin D kind of improve general health outcomes? It didn't. It was, if you're on Twitter, there's this nephrologist who I follow who's very thoughtful, Perry Wilson, and there was sort of an ancillary study to this trial that was running at the same time, and it was looking at whether vitamin D supplementation would reduce the risk of progression to chronic kidney disease in people with type 2 diabetes. He writes a lot about vitamin D. He calls it the Charlie Brown of supplements. And it was a negative trial, not negative in that it isn't informative, but it didn't show that giving vitamin D 2,000 units reduced the risk of progression to chronic kidney disease. And he says, rightly so, this is not a bad thing. This was a high-quality trial that tells us that we don't need to focus our energies here. Our patients have enough to do without worrying about which supplements they should take. And this really resonated with me because, as I mentioned, in long-term care, there were many other things we probably had to worry about, but I often distracted the conversation to long conversations about calcium plus vitamin D. And as I mentioned, I regret that. Pretty much every topic I look at, I'm just haunted by the things I did in clinical practice. So maybe, you know, vitamin D isn't used by everyone hoping to reduce the risk of cancer, cardiovascular disease, and improve survival like the VITAL trial tested. And most people, it seems to me, are taking it to reduce the risk of fracture, hip fracture, and falls. And the body of evidence is large in this regard. So this is the most comprehensive systematic review. 81 RCTs, 53,000 people. So it's not a shortage of vitamin D trials. We'll talk about the applicability in a little bit, but they were mainly community dwelling, mainly women. 60% were age 65 plus, and they were selected in these trials without any specific comorbidity. You know, like it was just your community dwelling, ambulatory. Let's see what vitamin D does for your risk of fracture, hip fracture, and falls. And this is the effect on any fracture, hip fracture, and falls. So what do you see here?
Close to 1.
Close to 1? Yeah. Yeah. Is it reassuring for hip fracture in any way, shape, or form?
Not really, right? Vitamin D supplementation did not have meaningful effects on fracture and falls. They tortured it with so many subgroups, you know, based on age, BMI, by baseline, vitamin D levels, by dose, by whether it was given intermittent versus daily, and they didn't really find consistent evidence of a different effect when they tortured it by subgroup. I will show you a couple that are very relevant to the people you care for, though. And I feel like there was one big missing subgroup, which is secondary prevention, people with a prior fracture. Because isn't that when we feel the most strongly about you should be taking calcium plus vitamin D? I used to have people started on calcium plus vitamin D immediately after they had a hip fracture in the hospital. Like immediately. They're coming from the OR and I'm like, you got to start this stat. Like, what was I thinking? I was applying guidelines is what I was doing. So there is one large trial, and it actually contributes most of the weight to the Boland systematic review, and it was previously community dwelling and mobile people over the age of 70. They were admitted to the hospital for a fragility fracture, and they were followed for 5 years. And I say it was the perfect trial because they were randomized to placebo, vitamin D alone, and calcium plus vitamin D. So, you know, test in all of those questions you have. And they looked at whether there was differences in any fracture or hip fracture. And this is the percent of people who experienced any fracture in these groups. And this is hip fracture. Thoughts? Were you like, have you, any other pharmacists here, you've been rushing to get people started on calcium plus vitamin D stat? Yeah. Like, we didn't even give them time to like start walking and eating, and here's your calcium 500 TID. I think the most important question, though, and something that isn't maybe discussed as well in that Boland review, is how well represented in clinical trials are people who live in long-term care. And so what's your experience anytime you look at the literature for people who live in long-term care? How well are they represented in statin trials, bisphosphonate trials? So you know where this is going to go, right? So Boland acknowledges there's limited representation of people at risk of or with marked deficiency. So that's just, you know, we can't just say vitamin D is useless for everybody. We have to acknowledge the people who weren't really well represented in this literature. So remember I said 85% of people were community dwelling, so 15% of people were in long-term care, so not a big body of evidence. But this is their analysis on that subgroup for hip fracture. Hazard ratio, point estimate of 1.12. Yeah? So not well represented in the trials, but then I also can't insist that vitamin D is going to reduce the risk of hip fracture because you live in long-term care. So the big point, and this will come to where I think Boland's recommendations are very sensible, is that people with true deficiency were also not well represented. So remember the National Academies defined true deficiency as less than 30 nanomoles per liter. They settled on less than 25, but close enough. Just 800 people in this body of literature, right? And the point estimate favors that vitamin D does something to reduce the risk of hip fracture, but you can see that confidence interval is really, really wide because there's so few people that this has been tested in. So I think that's an important place to point out where there is some uncertainty. And this might be patient populations and people that you worry about. So what happens if we give more? This comes up a lot, like the VITAL trial that gave people 2,000 units just didn't give people enough. That's why you can see all the comments on Medscape. They should have just given people more. I just want to explore this one particular dose initially. It just seems to me a lot of people are taking 4,000 units.
And the draft of that vitamin D guideline says the tolerable upper intake level for most adults is 4,000 units per day. And I mentioned I speak at an osteoporosis support group, and the woman said, my 4,000 units seems to be working. It just seems to come up everywhere. Is anyone else 4,000 units, or is it just in my world? It's just my world? It's kind of scary, hey? It's like, what am I doing with my life? Okay, so the National Academies translated, you know, the nanomoles per liter into intake that meets or exceeds the requirement for 97.5% of people. And so if you look at the age group above 70, 800 international units daily, and this isn't a, you should take a supplement of 800 international units daily, this would be total exposure, diet, synthesis, and supplements. And remember that these estimates are at the upper end of the spectrum of human need because most of us actually require less than this. And again, these were estimated under conditions of minimal sun exposure. 4,000 units has happened in a lot of different places. I would say it was more than just my world. They say the upper intake level is 4,000 units daily. And they wanted to be clear, this is not a recommended intake. This is just to relate to the 125 nanomoles per liter, which is the level above which risk for harm begins to increase. And they acknowledged, again, we're not recommending people take 4,000 units. But it kind of shows up in a lot of different places. So just as an example, this is the Multiple Sclerosis Society of Canada guideline in 2018, and they recommend that people with MS or at risk for MS supplement with vitamin D of 600 to 4,000 units daily. So you can see where those numbers came from. Yeah? Even though they go on to say that trials have not been powered to evaluate disease outcomes. So you will find, if you look, check, tell me, you'll see 4,000 coming up here and there. This case in the CMAJ last year, this 54-year-old man who is recommended to take 4,000 units per day. It's unclear why. He has hypertension, dyslipidemia, and gout. He inadvertently took 8,000 to 12,000 units per day, and he ended up hypercalcemic with acute kidney injury that led to chronic kidney disease. So it's worth checking in, I think. How much are you taking for people who are vitamin D enthusiasts? So back to that Calgary trial, there's this 4,000 units again. So remember, this is the Pure Energy sponsored trial. The people whose their website encourages high-dose vitamin D. Because world's experts suggest it, they say. They didn't have a placebo group, interestingly, but they had people take 400, 4,000, or 10,000 international units of vitamin D. I say they must have been mortified because when they looked at the differences in doses, there were actually greater bone mineral density losses with doses above 400 international units per day. And there was also an increased risk of hypercalcemia and hypercalciuria. So remembering these are people age 55 to 70, mean age 62, community dwelling, probably not very frail. It's interesting how they discuss this literature. They say because these results are in the opposite direction of the hypothesis, this evidence showing that high-dose vitamin D has a negative effect on bone should be regarded as hypothesis generating. And their conversation becomes, I think, a little plainer, although it hasn't been updated on their website. And I mentioned this Pure North website because many of the women at the osteoporosis support group I speak at, they're the ones who linked me into this. They say they're really encouraging high doses and high levels. And they acknowledge later there's growing evidence that for bone, the benefit of vitamin D supplementation is only seen in the treatment of vitamin D deficiency. Yet their website still encourages high doses, high concentrations for longevity, I guess. So you might know that in BC we've had experience with high doses in long-term care. In Fraser Health, this was a case series of giving residents 20,000 units weekly for a year. So that works out to be about 2,800 units per day. That's less than the 4,000 units per day, so we might think, well, it's below the upper limit, so I'm sure it's harmless. But it was 3.5 times higher than what the National Academies recommended as an RDA for people age 70 plus. What they looked at was what happened to people's vitamin D levels, and on average, at the end of the year, the participants' levels were 102 nanomoles per liter. They don't report the numbers of people who had levels of 125 nanomoles per liter or greater, defined as the National Academies as where harm probably starts to increase. They do report the numbers of people with levels of 100 or greater, and so I'm going to 52%, so half. So I'm going to take a leap of faith and imagine some people were above 125. 14% of people were hypercalcemic. So it's a little bit of a medical reversal here. They say with no proven benefit of high vitamin D concentrations in the residential care population, lower doses or even just enhanced vitamin D intakes through fortified foods would be recommended. And a study is needed to determine the vitamin D concentration of older adults entering residential care to better inform the need for supplementation. So where I showed you, why I'm suspect, at least in the community dwelling people, that there isn't a pandemic of deficiency, I actually haven't found studies looking at vitamin D levels of people living in long-term care. Maybe some of you have, and you can let us know. Well, this is why I call it medical reversal. If you just Google Fraser Health and vitamin D, this is what comes up. So the first line comes up, first in Canada, vitamin D now standard for all Fraser Healthcare residents, and then later discontinuation of vitamin D protocol in residential care. So they're moving toward individualized decision making rather than a universal order for vitamin D supplementation on an order set, and encouraging discussion of resident preferences and values. So I think the Boland article, if vitamin D is something you wrestle with or you're asked questions about, it's a really short read. What they come to, and they've been torturing this literature for many years, that there's little justification for the use of vitamin D to reduce the risk of falls and fractures. But they acknowledge an exception to this is for the prevention and treatment of the rare condition osteomalacia. And I thought this interesting because no one has said to me, I'm prescribing vitamin D because I think this person is at risk for osteomalacia. It's been very often for preventing falls. They identify people, of course, who might be at risk, those without a housebound, very limited sunlight exposure, severe malabsorption syndromes, that we might emphasize foods containing or fortified with D, and consider a weak recommendation because, the body of literature is very small, a low-dose supplement of 400 to 800 units per day. So I think this is sensible and it's not nihilistic about vitamin D, and I hope you'll, read the article, and I'd be happy to hear from you if you do. That's all I know. Just showing this picture. So I did this presentation in October, and I live in the Comox Valley, and I showed the journey of, we had a cougar on our property, using our property as hunting ground for a few weeks, so we were able to put up our trail cams. And our last picture is a snapshot of her, and you can't really tell, but that's her face, and she's actually pulling our camera down. So we had this nice little series of her hunting over a couple of weeks, and then she goes after the camera and takes it down. So for privacy reasons, maybe. That's all I know about vitamin D. Thoughts, questions?
Thank you very much for the presentation. This is really different from what I've been telling even today, I recommended vitamin D to a postmenopausal woman. So this is definitely something I'm going to read, and definitely different. Also for myself, I was recommended to take 50,000 international units of vitamin D every month by my doctor. Luckily, I forgot to do that, so I only took one dose and then had my level checked and it was normal. But I was sort of felt guilty that I wasn't taking what my doctor recommended.
I'm happy to hear that you were non-compliant. Thanks for sharing that. I think I might have to hit something. They said, oh, maybe microphones work in this room now.
I was wondering if pregnant women needs extra than what's in their prenatal vitamins, and the same for babies.
Yeah,
newborns.
so I just have looked at the evidence for adults. Does anyone know about the evidence for pregnancy and infants? I think it's always been recommended for breastfeeding, right? But for pregnancy, folic acid, yes. Does anyone know if there's any additional requirements for vitamin D? That's a great question.
We have been giving them extra 1,000 international units on top of their prenatal vitamins. There's 400 international units in the prenatal vitamin, but it sounds to me like that's adequate, actually.
Yeah, it's sounding like to me it's adequate, but again, I haven't looked at pregnancy specifically. That's a great question. Thank you. I'm happy to look at that. If you took down my email address, I'd be happy to look into that. Thank you. Yeah, right. Yeah, know your audience.
Do you know of any literature on the progression of atherosclerosis in the context of vitamin D and calcium?
Yeah, like sort of preclinical stuff? No, just the only trial that's really tested does it giving a supplement improve outcomes was the VITAL trial, and it was neutral for cardiovascular outcomes. But whether there's changes in preclinical atherosclerosis, I'm not sure. Yeah, I'm sure you'd find an observational study that looks at that for sure. I'd be surprised if you didn't.
I have a question. Some of the vitamin D supplements are packaged up with K2, which is supposed to do something about directing calcium into the correct space, being bones rather than blood vessels. Do you have any comments on that?
No, because I don't even know what that is. Other pharmacists here, what's K2, and why do we give that with vitamin
I have no
D?
idea.
It sounds very witchcrafty, but maybe there's something I don't know. Any other pharmacists? K2 with calcium to redirect it into the bones better. Is that what I'm to understand? I don't know.
I don't know.
Where's this packaged? What do you mean it's packaged?
There's been some studies in Japan regarding K2. I'm not really familiar with it, but that's where it came from.
I haven't done enough reading, I think.
Can you hear me?
Yeah.
I'm on calcium, vitamin D, and K2.
Okay.
From the naturopath.
Okay.
I don't think I'm going to take it anymore.
So I mentioned I present at the osteoporosis support group, and I showed all of this literature to them, and it's women who range in age from 50 to 90, and it's so fun. And I think the most common decision is I'm taking too much. There are some that decide I'm not taking it at all, and there are others who are like, I'm rather hopeful, I would prefer to take it, and we just talk about, don't take too much because that's harmful. So people reach different conclusions, and I think that's totally cool.
So I just quickly Googled for the sake of it.
Oh, cool.
Infants that take vitamin D and the usual dosage in Canada, what they recommend is 400 international units daily for babes that are breastfed.
Oh, for breastfeeding, right. Thank you for checking that. It's good having people here with phones. So yes, they need it.
Well,
I think one of the hard things for me is that choosing wise and all these other initiatives, we're not supposed to be doing vitamin D tests.
Yeah. Mm-hmm. I bet. Mm-hmm. Mm-hmm. Mm-hmm.
Study where they did a few levels here and there, and they determined what latitude. But I guess my question is, do you have any sensible recommendations of, is there now a new rule for testing given?
Yeah, so the Boland review suggests not. And I think many people have become rather pragmatic because of the cost of vitamin D tests. Like you'll see most guidelines will say, oh, it probably doesn't hurt. Tests are expensive, so just recommend a low dose. They don't really make a strong recommendation for tests. They just, you know, if your clinical suspicion is that this person is at risk for the severest of bone conditions, osteomalacia and rickets, then supplement with a low dose.
But only if you know they would take the medication before you do the testing.
Yeah, that's a good point. Yeah, yeah, it's a good point. Yeah.
So I'm from Jamaica, and someone like me who's not melanocyte challenged, and spent all my early life in 90 degrees playing cricket for 8 hours a day. Is there some limiting factor of melanocytes in the amount of sunlight I absorb, and would probably not let me have 100,000 units of vitamin D a day? Yeah.
Yeah, the vitamin D supplement studies, you're right. Yeah. So I don't think you would not be well represented in the randomized control trials. I know, right? But the national academies took into account, like, you know, skin color and all of that, and so these recommendations, they wouldn't be saying to you, you need to take more vitamin D. They've sort of taken that into account. I don't think you need to start taking what was recommended to another fellow, 50,000 units monthly or something. I don't think you need to do that. Yeah. You probably want to go home, and you know that's almost my bedtime. So I think just in primary care, kind of checking in with people how much they're taking, because once I did start asking, it really surprised me. As I mentioned, my closest friend who was taking 8,000 units. And just wanted to let you know we've connected with Fraser Health, and they're just really trying to revisit how they make these decisions and focusing on individual preferences and values versus you got to be on vitamin D because you've just entered long-term care. But they're not being nihilistic about vitamin D either. So I think there's an important balance there. I'd like to, if you have questions or comments, or I want to look into a couple of questions over here. I think my email address is somewhere, or can be somewhere, maybe at the beginning. Thank you.
Hi, everyone. Before you go, sorry, one last announcement. It won't be long, I promise. All right. So one thing before you go, thank you so much for coming, and thank you so much to our speakers for presenting. I heard that they came from Up Island as well, so a big round for them. Also, if you can, when you take your name tags off, if you can just put the strings inside, it's a little thing that goes a long way, and you know you made someone happy tonight. And if you can just drop them off, there's a table at the front, and then also you can put your evaluations there, and then you can pick up your certificates as well. All right, thank you so much for coming, and yeah, have a good day.
It's very interesting, and there's still so many questions.